Yeah, I'm Howard Molinsky, co-founder of ASPI. I've been on active surveillance for 10 years. I used to think of active surveillance as a non-treatment, compared with radical prostatectomy or radiation, but I was wrong. The diagnostic and monitoring tools used in active surveillance can have consequences, even lethal ones, although rare, with transrectal biopsies. My doctors at least warned me about the potential for infection and sepsis. Not all doctors do, but I just shrugged, feeling that I had to take my medicine, so to speak. It was part of the drill. I've been lucky so far, having had 6 transrectal prostate biopsies. Now, today, we're here to talk about the risks we all face with transrectal biopsies and a safer new alternative, transperineal biopsies. The transrectal is what it says. It goes through the rectal wall. And so it's a filthy, dirty place, like you all know, and it has potential for infection and, in worst case, for sepsis. Transperineal goes through the taint, and maybe one of our doctors can explain what it is versus what it ain't. And I'm going to introduce our speakers as we go along, and then we'll go into a question and answer period. If you have questions in the chat, put them in the chat box where David Keller will curate and read them. I will add links to some of the pertinent articles as we go along. I've already put in a listing of the speakers, and there is a link to Agnes's story. At any rate, our first speaker is Dr. Ferdinand Becker, who is here not as the medical doctor that he is, but as a fellow active surveillance patient. Ferd is one of the first members of A.S.P.I, and he nearly died from sepsis, so from a transrectal biopsy. So Ferd, why don't you take over?
Thank you very much, Howard. Thank you, Mark, for inviting me to participate in this meeting. I think it's highly important. I had a strong family history of prostate cancer. My father died of prostate cancer at 85 years, and his brother had prostate cancer and died of that. Another brother had metastatic prostate cancer and died of heart disease. Anyway, for years I took supplements and tried to prevent prostate cancer, and ultimately in April 2011, my PSA went up over 3 years to about 5.5. When I had my biopsy in April 2012, about 5 days later, I got sepsis, and it was on Easter Sunday, and my urologist, my good friend, came down to the hospital and got me worked up. I had a temperature about 103.5, and I had delirium, my wife said. And then fortunately, the powerful antibiotics they gave me treated the sepsis, and I recovered. But it could have been worse and worse.
It's time to move on to Richard Szabo, who's a professor at University of California, Irvine, who's written extensively about the risks and costs of transperineal versus transrectal. And I'm hoping you can explain to us what these two procedures are, how they're different, and what difference do they make in terms of sepsis.
I'd like to talk a little bit about transperineal prostate biopsy, which is a better, safer biopsy. I first wanted to find out about transperineal biopsy when I had a patient who got septic, just like Ferd here, but he unfortunately suffered much worse complications. His sepsis became very serious. He almost died overnight, and he developed a brain abscess and no longer could talk or walk, and his wife now gives him 24-hour care and changes his diapers 10 times a day. And this is a healthy, vigorous 65-year-old man who just had retired. So that tragedy and other cases of sepsis kind of spurred me on to look a little bit into how I could prevent this in the future. So I guess we'll go like this. Transperineal here is on the left. As you can see, the needle now is going into the skin to get to the prostate. Here's the rectal probe down here. This is transrectal, where the probe goes into the rectum and the needle goes through the probe and then out of the probe into the rectal wall. A more diagrammatic look is to see how transperineal needle goes directly here into the prostate through the skin. Transrectal needle, also transfaecal, as Mr. Popert would say, goes through the rectal wall, and we all know what's in the rectum here. The other thing to note is that the transperineal needle can more easily access this part of the prostate, the apex and the anterior part of the prostate, where 25% of prostate cancers are harbored. So what is sepsis? The Google translation, first thing that comes up is it's a serious condition resulting from the presence of harmful microorganisms, bacteria, in the blood or other tissues in the body's response to their presence. And this potentially leads to the malfunctioning of various organs, shock, and even death. So when people say, well, you know, it's a rare complication, you know, let's just keep doing what we're doing, and you know, this is what we need to accept. Complications always happen. Well, I like to remind everyone, this is a semi-elective procedure that is not emergent, and it's most of the time done to just screen for cancer. This is not to treat for life-threatening disease. This is just a screening test. And so I always ask, what would you do when faced with the chance of developing sepsis after a biopsy of your prostate? It's analogous to flying nonstop from Los Angeles to New York, and knowing that if you're one of 100 passengers on that flight, that you have between a 1 in 3 chance of developing sepsis, or a 5 to 7% chance of having a urine infection or a prostate infection. But let's say we instead stop in Denver for a 1-hour layover, so a little bit longer procedure, and then fly on to JFK. And if the risk is 0 sepsis, my question to everybody is, which flight would you take? So transrectal biopsy has several disadvantages. It's inaccurate, not just the sepsis problem, but it's inaccurate. We all know that it has a high false negative rate. It misses about 1/3 of the clinically significant prostate cancers. We know from looking at prostates that have been removed that the transrectal prostate biopsy understaged up to 25% of men. So they didn't realize how serious their biopsy was, rather their pathology was. And maybe the wrong operation was done. Maybe it wasn't aggressive enough. Transrectal biopsy is dangerous. There is a rising incidence of infectious complications after transrectal biopsy because of increasing antimicrobial resistance. So as I mentioned before, the American Urological Association white paper in 2016, and this is 5 years ago, things are probably a little worse now with even more antimicrobial resistance. The urine and prostate infection rate was 5 to 7%, and sepsis requiring hospitalization, 1 to 3%. When we talk about death, it's actually difficult in our large databases to truly quantify the number of deaths from transrectal biopsy. Johansson et al. Did a study in Norway, and they documented about 1 in 1,000 deaths from transrectal biopsy, and Y et al. In Taiwan documented a similar number. Transrectal biopsy is therefore costly. If we're doing almost 2 million prostate biopsies in the United States per year, and let's just say we have 2% incidence of sepsis, that gives us about 39,000 cases of post-transrectal biopsy sepsis per year. When you extrapolate the cost of these hospitalizations, and this has been shown by a group from the Brigham and Women's Hospital, when you add up the number of cases, it's up to $750 million a year is the cost. So it's quite a significant amount of money, and it adds almost $300 per biopsy in real cost for insurance companies. So transperineal biopsy is, when you compare it to transrectal biopsy, is more accurate, more safe, and less costly. When you couple it with MRI ultrasound fusion targeting, the yield of clinically significant cancer is 50 to 60% greater than the yield using transrectal MRI ultrasound fusion targeting. So it's especially effective in detecting cancer located in the anterior prostate. Two studies came out in 2019 illustrating this. That first study, Bear et al., is actually level 1 evidence. And this is hot off the presses. Transperineal prostate biopsy improves the detection of clinically significant prostate cancer among men on active surveillance. This is from Dr. Gorin's group. I'm just going to quote from the abstract here, show you that 21% of the transperineal prostate group were upgraded to grade group greater than or equal to 2, compared to only 14.7% in the transrectal biopsy group. And in the anterior zone, it was 44% compared to 18.7%. So again, illustrating how transperineal biopsy is way superior in detecting these often hidden prostate cancers when patients are undergoing transrectal. The anterior prostate cancer is often missed. And when we talk about even higher grade cancer, the transperineal prostate biopsy was doubly effective compared to transrectal biopsy. And transperineal biopsy is safe. In my review, I found about 7,400 cases and that had transperineal biopsy only under local anesthesia. The percent sepsis was 0. This is compared to 1 to 3% for transrectal biopsy. When we included patients who had intravenous sedation or general anesthesia, the incidence rate was about 2 out of 10,000. And likely this was associated with the urinary retention one gets more easily when one is put to sleep with sedation or general anesthesia. Rectal bleeding, this is something that we don't mention very often. It's never going to happen with transperineal biopsy because you're not putting needles through the rectum, just the probe. But with transrectal biopsy, 2.5% of cases go to the emergency room. This costs us about $54 million in the United States. Why, despite this recent evidence, are many urologists, the majority of the urologists in the United States, not converting to transperineal? Is it a perceived need for the use of general anesthesia? Because transperineal used to be done not as I had shown in the previous picture, but with these complicated stepper units and grids that are fixed to a table, and the way it's done is many pokes through the skin instead of a couple of pokes. Is it because of increased cost? Is it going to cost the urologist a whole lot more to do? Does the procedure take much longer? Is it more painful? So I say get with it. The literature review that I did found a very large number of freehand transperineal cases under local anesthesia without sedation. And a transperineal biopsy, therefore, can be easily integrated into a normal urology office workflow with only local anesthesia. Is there increased cost? To whom? There's really no need for general anesthesia, as I just mentioned. And as I also mentioned before, the sepsis costs up to $380 in addition to what it costs for a transrectal biopsy when you consider the sepsis complications. These costs are charged to Medicare, insurance companies, and through them to you. Australia has understood this, and the remuneration by the government for transperineal biopsy was increased by 20% and decreased for transrectal biopsy by 50%. In the UK, Mr. Popert just mentioned to us that over 70% of the prostate biopsies there are now done through the transperineal approach. The procedure time. On average, in my literature review, among the studies that reported procedure time, the average procedure time was 19.1 minutes. Guo et al., who did a comparison study, found that for transrectal biopsies, his average procedure time documented was 14.7 minutes. But I must remind everybody that transrectal biopsy is usually done with fewer biopsies than transperineal, likely because of the fear of sepsis and rectal bleeding. It's less aggressive, which may not be the right move. So a little bit longer for transperineal biopsies. What about the pain scores? How much pain does one experience with transperineal versus transrectal? In my literature review, of the 3,868 cases that reported the pain scores, the average pain rating was 3.17. When I averaged the pain scores over 10 studies I found in this paper by Tiong et al., the pain rating averaged at 2.6 out of 10. So 3.17 divided by, 3.17 compared to 2.6, not that much different. And a recent paper came out showing that they could decrease the pain rating from 3.3 to 1.8, injecting in a different way to the branches of the perineal nerve. So in summary, my literature review found about 12,000 cases of freehand transperineal biopsy reported in just the last few years, most of them in the last 5 years. And it demonstrated that transperineal biopsy is superior in safety because it virtually eliminates post-biopsy sepsis and rectal bleeding. It's superior in accuracy with a higher detection rate of this clinically significant cancer. Not a cancer that's low grade that you don't really want to know about because we don't do anything about it most of the time, but it's higher detection rate of clinically significant cancer using MRI ultrasound fusion targeting. And the cost would, if we all adopted it in the United States, would be, we would be saving $752 million a year. Transperineal is comparable to transrectal biopsy in pain score and procedural time. Thank you for your attention.
Well, thanks for the visual pun with the end. Next up is Mr. Popert from Guy's Hospital in central London. He became an early advocate for transperineal because he too had a very bad experience with a patient, and he's been a leader in a movement called Trexit. Don't get it confused with Brexit. I don't know where he stands on Brexit, but on Trexit, which is transrectal exit, Trexit. I know where he sits, and I think I know where he stands. But at any rate, Rick, if you can take over.
Thank you, Howard. I'm going to share my screen, and hopefully you're getting that title screen.
Mm-hmm.
So it's a great honor to speak to such an international group of patients who have such a common interest, which is how they can live with a prostate cancer that they know now tends to progress very slowly and far more likely to die from heart attacks or strokes than from their prostate cancer. But there's always that uncertainty in patients on active surveillance. And uncertainty is that, have they been mischaracterized? Has their disease been mischaracterized? I mean, the talk that Ferd gave about the fact that they mixed up his MRI scan and he thought he had locally advanced or, you know, metastatic prostate cancer, as bad as that. And in fact, he didn't. And here, 12 years later, he's living well. And you, Howard, living comfortably on active surveillance. And all of you doing so. But there will be people who will continue to be concerned and worried, because active surveillance requires trust, and it requires trust of your surgeon, and it requires trust in the investigations that have been done. And that's one of the things that, for me personally, as a surgeon, where I operate on people and I do brachytherapy and I do biopsies, I want to try to resolve the uncertainty so that patients will be able to make the appropriate decision with the best information available to them. And when I started in practice back in 96, 97 as a consultant, the only option we had was transrectal biopsy, standard radiotherapy, and open radical prostatectomy. There were no other choices, and people didn't really go for active surveillance. It was really something that wasn't even discussed. So I do have some disclosures of relevance to this talk. Now, it remains worldwide that the current prostate cancer diagnostic pathway is that you have a PSA blood test done, and the PSA blood test is elevated. You then visit your doctor's office, and he will then carry out a rectal evaluation of the prostate gland, and then will probably make a recommendation if the PSA is abnormal and the rectal examination is abnormal, or even if it's normal, that you should have a transrectal biopsy. And the problem with the transrectal biopsy, as you can see in the bottom picture, is the transrectal biopsy samples the posterior portion of the prostate very well. But the anterior portion of the prostate, which is the little bit I've outlined in blue, is actually very difficult to approach transrectally. So it's a sort of a blind spot when you're driving down a motorway. Oh no, well, we call them motorways, but a freeway. You get a blind spot, and you know there's a lorry coming up your blind spot, and you never even saw him, and you were just about to pull out, and what's going to happen? Well, you're going to end up in a big crash. That is the problem. My colleague Tim O'Brien in my hospital, who's now president of the British Association of Urological Surgeons, coined the term transfaecal prostate biopsy, because the truth is, it is. And, you know, here, you know, one can imagine sitting there and the doctor's telling you that you need to have this biopsy, and I'm going to put this probe in your back passage, and I'm going to take some biopsies through your back passage into your prostate, because that's the easiest way that I can approach it, and that's the best way of doing it. But transrectal, transfecal prostate biopsy, you have to understand, the rectum is a dirty box. The prostate is a clean box. And the problem is because those two things do not go together well, that there is a risk of sepsis. Now, 15 years ago or more, when I did my first transrectal biopsies, we didn't use local anesthetic. We rarely gave antibiotics. You just did it. And then when I started doing the antibiotic, we started seeing patients with sepsis. We started introducing various types of antibiotics, an antibiotic into a vein, an antibiotic into the back passage, and then some tablets to go home with. So as long as you gave them the antibiotics, everything was fine. But that was 20 years ago. And we all know that bacteria and these organisms and viruses have this incredible ability to move out of the way of the thing that's coming along to stop them. And that is a problem. And it really does not matter. Even if you use the highest quality antibiotics and the highest quality antibiotic surveillance in order to try and identify the correct antibiotics that you should give. And you can take swabs of the back passage and say, well, okay, we've got this organism, we know it's sensitive to this antibiotic, so we'll make sure we give them this antibiotic. And anyway, it's twice as expensive as the old antibiotic, so it's got to be better. Well, it isn't always. And the problem is even in the best hands, you cannot eradicate sepsis related to transrectal biopsies. And whatever way you count the numbers, we talk about 1 to 3%. It is rare, but it's always, even in the best hands, even the people who say, well, my sepsis rate is only 0.5%. Well, that is 1 in every 200 patients. And you think how many patients are having a transrectal biopsy worldwide. And it's certainly a lot of patients. We're going to be talking about the experience of a lady and her father, who tragically died of a septic embolus. And it wasn't actually sick. I've got here 6 days post transrectal biopsy. It was only within 3 days. This was a fit man and he died. And she wanted to know why. And because she'd been helped by her own urologist, and I'm sure they'll give you the more of the story in detail, which makes my skin crawl every time I hear it. But what they did was the Norwegians, they went back and looked at resistance to antibiotics that they had documented previously to one antibiotic, trimethoprim, and another antibiotic, ciprofloxacin. And what they found was that the infection, the resistance rates to antibiotics had increased dramatically. And they also found that 10% of all patients having their biopsies underwent a hospitalization within 60 days of a biopsy. And they are changing their practice because they've been forced to. I had a patient who was a charming gentleman, and I remember speaking to him about his life, and he'd been a very successful man, and he was in his 50s, he's younger than I am now, and he'd made his money, he'd had his children young, they were all happy, he was happy, and the thing that he enjoyed more than anything was walking up mountains. He was a climber, but he just basically just loved going up mountains. And in Europe, in Switzerland and Norway, we have these mountains and the most beautiful views. And what he gave his life to in his retirement was to actually climb and walk up to all these mountains and enjoy his life. But there was a problem, and the problem was that he had an elevated PSA blood test. Now, because he had the PSA blood test that was elevated, he came to me and I sat him down and I said, well, there's possibility you might have prostate cancer. That's why your blood test is raised. So we discussed it and we discussed the risks. And I told him there's a risk that you get infection, but I'll do my utmost to make sure everything's okay. And he trusted me. He trusted me with his life. As it happened, he didn't lose his life, but he came very, very close to losing his life. And that was in 2005. So I did the transrectal biopsies. I gave him the appropriate antibiotics, and we didn't find that he had any cancer, but he developed life-threatening sepsis, ended up on the intensive care unit, diabetic, renal failure, ended up on dialysis, and he never climbed a mountain again in his life, but he still thanked me because I hadn't found any cancer. Now, for me, I was just blown away by the experience of managing this patient because I'd lived every day he was sick. And so in 2006, I'd already been doing transperineal procedures because we'd started doing prostate brachytherapy. So I had an idea about the perineum and I operated on prostates. And I said, right, we are not going to go forward with any transrectal biopsy in our patients. And I was fortunate, I was the senior consultant, I was in charge of the department. I just said, no, it has to stop. But we couldn't translate all of our biopsies to transperineal, that wasn't possible. But we set some guidelines and we said any patient that was at risk of sepsis, so that would be diabetics, people who'd had a previous urinary infection, people who'd had a large prostate with symptoms, which is what my patient had, patients who'd had antibiotics, or they traveled to Asia or Africa where you can pick up very funny organisms in your bowel, they would not get a transrectal biopsy. They would move to a transperineal biopsy. The other thing we said was any patient who was thought to be suitable for active surveillance based upon a transrectal biopsy should have a transperineal biopsy to confirm that they were suitable for active surveillance. And any patient who'd had a previous transrectal biopsy in whom the biopsy was negative, big relief. No cancer. My biopsy's clear. The doctor says I'm absolutely fine. But then a year later, the PSA's doubled and the PSA's gone up. And then you're back in the office and the doctor says, well, your biopsy was fine last year, but we better check again. Well, I said, right, nobody gets a second transrectal biopsy. They got away with it once. Howard, you've got away with it 6 times. I don't know how, but they got away with it once. All of our patients will be offered a transperineal biopsy. Now, they may not choose to have that transperineal biopsy, but they were offered it. And any patient where they had an MRI scan, where there was an obvious anterior abnormality, we would make sure that we took targeted biopsies, and also it became patient choice. Now, when I started doing this, what we found was 36% of all patients who'd had a previous negative biopsy, actually we found cancer. And all of those patients chose definitive treatment because their cancer had been missed by their first biopsy. So they didn't, even if they were suitable for active surveillance, they wanted treatment. 37% of patients who we thought were suitable for active surveillance based upon their initial biopsy actually had higher grade or volume of disease, and we were able to offer them early definitive treatment, curative treatment, because they needed it. And where we did this transperineal biopsy as a primary biopsy, and remember, this approach predated the use of MRI scan up front before biopsy, which is what we do now, we were identifying cancer in 63% of the patients, and 15% of them had disease exclusively in the anterior sectors. And it's very reassuring to me that Richard Szabo, in his review of all this evidence over the last 10 years, it's all the same. Transperineal biopsy picks up more cancer. But the problem is many people who don't believe it say, well, it picks up more cancer because you do more biopsies. You're taking more specimens, so you pick up more cancer. And that may be true to a degree, but it's not true for everybody. And the most important thing, and this is the reason why the European Association of Urology have now declared in their guidance that the recommendation for prostate biopsies should be transperineal. What they haven't said is how that should be done, but they've made that recommendation, not because transperineal biopsy is a better, safer biopsy, as Richard said. They've made that recommendation because of the potential risk for sepsis. And the fact is, in Europe, they have virtually banned the use of a particular type of antibiotic called quinolones, which people might know as ciprofloxacin or ofloxacin. And these antibiotics are the ones that stop sepsis in transrectal biopsies. So if you say you can't take that antibiotic, you actually increase your risk of sepsis considerably. And that is a real problem. Now, when we did these biopsies, we had no sepsis and we had minimal complications. And so I was very happy with this approach, but we carried on doing transrectal biopsies in patients. And it was by about 2012, we were about 50% transperineal, 50% transrectal biopsies. And myself and a colleague have looked at all the biopsies done over the last 5 years, since 2012 in the UK. And we've looked at the data that's come out from the NHS. And in between 2012 and 2016, about 17% of all biopsies were transperineal. By 2017 to 2019, this had increased to 33% of all biopsies are transperineal. And that is quite a lot of biopsies in the UK. It's over 100,000 biopsies. But that still means that 400,000 biopsies were being done transrectally. Now, this is quite recent data, and this graph shows in the sort of the reddish color to the left of the screen are those hospital trusts. These are hospitals in the UK that are doing transperineal biopsies, and the hospitals in the UK that are still doing transrectal biopsies. Now, some of these hospitals will be double counted because many of them will do some transperineal and some transrectal. but you can see that the majority of the burden of sepsis is firmly in those hospitals that do predominantly transrectal biopsies. And this is data from 2017 to 2019. When we get data from 2019 to 2020, this change will be even greater. And when we get the data from 2020 to 2021, which is in through COVID, I think we'll find actually our sepsis rates go down because we're doing less transrectal biopsies in COVID and we're doing more transperineal biopsies. So this is data that I'm very keen that we get soon, and hopefully at some stage I may be able to share it with you. Now in the UK, nobody gets a prostate biopsy without having an MRI scan. And in some ways that makes it very easy, because if they've got an obvious cancer, then you can take a biopsy from that area using various techniques. If only just looking at saying, okay, well, that's the side that looks abnormal, so we'll take some biopsies there. And that's very, very effective. And you can use that to reduce the number of biopsies that you do. And therefore people say, well, you can do that and you can use transrectal biopsies. You don't need as many biopsies, but you will still have some sepsis. And you cannot avoid the sepsis. It will still be there. It will never go away. Now, why don't we do transperineal biopsies for everybody? I'm sorry, I don't know why my slide went away, but I hope you got it back. We don't do transperineal biopsies for everybody because most of transperineal biopsies require a general anesthetic, and it generates waiting lists and delays to the pathway of treatment. And you can do these biopsies under local anesthetic, but as you can see, it's the same equipment, the patient, everything's being held out there. And I would call this tolerable, not comfortable. Now, until I was introduced to this device, which is the device invented by Matt Allaway, who's a urologist. And when I saw this device, I realized for the first time that I could do a transperineal biopsy effectively to sample areas of abnormality in the prostate and do biopsies of the rest of the prostate under local anesthetic, because I wanted to be evaluate. This is sort of diagram shows a prostate gland, and that's a lesion on one side of it. And I wanted to be able to identify cancer in the lesion, but also do some biopsies elsewhere. But I'd like to be able to do that under local anesthetic in the outpatients. Now, this little video shows you what we can do
in decades, and it's all down to this. It's called the PrecisionPoint Transperineal Access System, and it's revolutionizing biopsy procedures.
Hello, Paul. Okay, so what we're just going to do is just run through briefly what we're going to do inside the operating theatre. My name's Rick Pope, I'm a urologist, and I've had an interest in prostate biopsies for many years. I became offended by the principle of transrectal biopsies over 12 years ago when we had patients who had significant sepsis.
Transrectal biopsies have been the standard technique for over 30 years, but they risk infection and false negative results. Rick Pope then moved to transperineal biopsies, but needing a general anesthetic, it's resource heavy and expensive. Now all that has changed.
Little scratch on the skin, right? Little scratch. I then use some local anesthetic to inject into the skin.
The new PrecisionPoint device is attached to the ultrasound probe, and it's used to guide the anesthetic needle to the prostate.
And then we put a deeper injection up towards the two sides of the prostate. Here comes the needle now. A little uncomfortable. Very good. And then we're just injecting the local anesthetic then. Perfect. So that's one side done. And now we've just got to do the same thing just on the other side as well. A little uncomfortable now. There's the injection going in there. It's already numb. Okay? So you happy for me to take the biopsy? Good. All right? Yeah, absolutely. So you feel a bit of pressure now, and you're going to feel just a little bit more just pressure, just as I pop the needle towards the prostate. Was that painful, or was it just the pressure? Pressure, not painful at all. You'll hear the sound of the biopsy gun going off, which sounds a bit like an air gun. And you may get a feeling just a sort of little jump. this sort of area is impossible to really target accurately with the standard biopsy. So this is why this is a better biopsy, really. And now I'm just going to walk my way across the top of the prostate.
I wouldn't say it was pleasant, but it's nowhere near as bad as I anticipated, to be perfectly honest with you.
The idea behind it is fiendishly simple and elegant.
So it's the movement of the probe up and down, which tilts the prostate to meet the biopsy needle, which allows you to use one puncture.
No pain whatsoever.
It's revolutionized our practice. It's allowed us to do more of our transperineal biopsies under local anesthetic in the outpatients than we've ever been able to do. It allows us to reduce the need for general anesthesia such that the majority of patients can be done under pure local anesthetic and some with a small amount of sedation if necessary. But the beauty of this thing is that I'm only making 2 punctures just in the skin, and yet I'm taking 27 biopsies in total.
No words, it's very quick. For a very, very thorough, I could see how thorough that was.
And once the procedure's done, we just check your blood pressure, sit you up, and hopefully walk you out a cup of tea, and then home once you've passed some urine. I suspect that Norway will probably beat us to abolishing transrectal biopsy, but I hope that we won't be far behind. The Trexit initiative, which we established at my hospital, has now expanded across the South East London Cancer Network, which is a population of 1.5 million. We stopped all biopsies transrectally there in March 2019. Around the UK, between June 28 up to June 2018, there were only 12 centres doing biopsies using the transperineal system, but that was within 6 months of us achieving the CE mark. By December 2019, over 70 centres were routinely using it. And then, of course, we had the pandemic. And it's interesting, the pandemic has driven people to do biopsies under local anesthetic in the outpatients because they don't have access to general anesthetic operating lists to do their standard transperineal biopsies. So they're falling over themselves to learn the techniques that we've developed along with Matt Allaway. And I think in some ways the challenges of COVID are the opportunity that we're grasping now, because we've now got over 140 hospitals in the UK that are routinely using local anesthetic transperineal biopsies. And that's not just with the PrecisionPoint system. There are other systems that are available. And people are realizing that transrectal biopsies are just not worth it. So I believe that a local anesthetic transperineal biopsy is a better, safer biopsy, and it is fit for a COVID future. And the time is for Trexit. And that, I believe, is the most important contribution that the modern science can make to urology. It's far better than MRI scans or anything. Why, as a urologist, would you push something through the rectum into something that is clean? My old colleagues never would have imagined doing transrectal biopsies. They all did them transperineally, and it wasn't until we'd invented the ultrasound. And it's interesting that transrectal ultrasound was developed in the Scandinavian countries, and it was from there that transrectal biopsy started. And yet it's the Scandinavian countries that are leading part of this move away from transrectal biopsies. So I hope you've enjoyed the talk. I think what you're doing as a group is absolutely fantastic. Take up the opportunity and insist in your active surveillance that you must have an MRI scan, because that may identify a lesion that looks abnormal, And also do not accept a transrectal biopsy if there's an opportunity to get a transperineal biopsy. Thank you for your attention.
Well, thanks, Dr. Popert. And for the moment, we're going to remain in cyberspace, hovering around Britain, and speak to Dr. Popert's associate, Jonah Rousser, who is a urological nurse. And at Guy's Hospital, and I gather elsewhere in England, they're moving this procedure, or they're expanding this procedure to the hands of advanced practice nurses. And I have to give Jonah a plug as the Urological Nurse of the Year in the UK for his work in this area. So Jonah will be speaking about his perspective. So Jonah, the ball's in your court.
Thank you very much. Can you hear me?
Yes.
Thank you. So my name is Jonah. I am one of the urology nurses at Guy's Hospital, where Dr. Popert works. And it would be unforgivable if I start the talk without mentioning how privileged I am to be sharing the floor with Dr. Szabo, Dr. Matt Holloway, and Dr. Popert. I'm extremely privileged. And I would like to extend my gratitude to Dr. Popert, really, who's been very influential in my career, without whom really I wouldn't be speaking to you right now. So thank you. And thank you for inviting me to your platform, Howard, to speak to the patients, to your colleagues. Thank you. So my name is Jonah. I work at Guy's Hospital with Dr. Popert. And just got my disclosures really. And I'm here, I'm just gonna discuss the PrecisionPoint, which was the device Mr. Popert showed you earlier on in his talk. And when I say LA, it represents local anesthetic and TP's transperineal biopsies, training for nurses. I'm just gonna briefly talk about my journey, how I came from transfecal biopsies to local anesthetic transperineal biopsies. Also talk about the biopsy course that myself and Mr. Popert have put up for the nurses and what the future looks like. So Mr. Popert, I think in 2018 said that nurses are the key to achieving Trexit, as they will be the ones delivering the majority of the work in the office setting. And this is truly our experience at Guy's Hospital. For example, if I give you an example of how many biopsies I have done, in the last week, I have done 30 biopsies at Guy's Hospital. And if I break that down to you, it'll be, last Sunday, I did 7 biopsies. Monday, I did an all-day list of 6 biopsies. Wednesday, I did another all-day list of 6 biopsies. And tomorrow, Sunday, as we speak, I've got another 7 biopsies waiting to be done at Guy's. This just put things in perspective according to his statement. Because if I wasn't doing this biopsy, it would take Mr. Popert and his colleagues from doing other procedures they could be doing, such as HOLEP, prostatectomies, to cover the biopsy list. So this is what he meant. I myself at Guy's Hospital with my colleague, another nurse called Grace, we are doing the majority of the work. And this is what he meant by the statement, and it's truly been prophetic. So my journey, personally, I joined Guy's Hospital in 2014. I had no prior experience of doing biopsies at all. Actually, I left my previous hospital because I had asked them for the opportunity to learn how to do transfecal biopsies, and they said there was no opportunities for nurses to do here. So I applied at Guy's Hospital, and they said they'll be willing to teach me. So in 2014, I learned the transfecal biopsy method and I mastered it. I became very good at it. I became very proud of myself that finally I've reached that goal that I always wanted to do biopsies. And here I was. So I was in a career-wise, I was in a very good position. I felt I had achieved something. That was until, as mentioned by Dr. Popert, that Mr. O'Brien, who was the lead for urology at that time, said he didn't want any transfecal biopsies done at Guy's Hospital from September. So in September, Guy's decided to close the door and walked away from transfecal biopsies. And that's when Mr. Popert named it Trexit. For me, as I'm speaking from a personal point of view, Trexit was not welcome. If you understand, I was told that we're not going to do trust biopsies mid-August. So I was told by the end of the month, which was 2 weeks, you're going to lose your skill. Something you mastered, you're not going to have it anymore. So for me, to say the least, from a personal experience, it was devastating. And this is the case that we're finding with most nurses across the country, that as they're being given the news of Trexit, they are losing the skill. So the plan B was to learn how to do the grid template biopsies, but these were not practical because it's not possible for a nurse to have a list in the operating room. So this was not feasible for me. Then plan C, I'm sure Mr. Poppet will remember, he was in clinic one day speaking to his junior colleagues, and I just crept up next to him and I said, could you please show me how to do the local anesthetic transperineal biopsies? To my delight, he agreed. He was actually pleased. I think he seemed to be taken back that I wanted to learn this technique. So he took me under his wing and he signed me off after 20 biopsies, after where he was supervising me and teaching me. And ever since then, we've been leading a nurse-led biopsy services at Guy's Hospital. And I say nurse-led because mostly these biopsies, as I explained to you earlier on, are being done by nurses. Okay. Then I got the job satisfaction back. I had a new skill and I was able to be professionally proud again of myself and achieved my goal. And so the first course was the first local anesthetic transperineal biopsy course was in February 2018. I was so pleased that the British Association for Urological Nursing took this on board and also did the charity Prostate Cancer UK. They were excited and they endorsed the course. I mean, we have trained about I think it's way over 100 now. Nurses have attended this course. So after the course, because it's a one-day course, they've only seen 3 or 4 biopsies. We discussed with Mr. Poppet again. We said, okay, I do a list on a Monday, Wednesday, and every other Friday. I said, let's give them the opportunity that nurses can actually come on a weekly basis to shadow my list. So this way they get a one-to-one lesson. Whether it is they come for 1 week or for 6 weeks, it was up to that individual how many sessions they needed to understand. Then when they're at a level where they understand the theory part of it, I or Mr. Poppet would then support them, would encourage them to put a full day list with about 5 patients in their own hospital. Then we would actually go and visit them and support them on their list. So they would be the ones sitting on the chair and we will be verbally directing them on how to do the biopsy. Therefore, we're bringing the theory they have gathered and the practical session. And we've trained up to about 20 nurses across the country. These are nurses that I or Mr. Poppet have trained from beginning to the point where they are competent. Other hospitals that Mr. Poppet has trained the doctors, some hospitals are taking the initiative to train their own nurses. So there's way, way more than 20 people across the country doing this. And now I'm happy to say a lot of nurses can see that it's possible and to be able to gain that skill back and they're able to deliver the service in their office setting independently. Currently, the course, we haven't been running face-to-face due to the COVID. It's been a webinar which Mr. Poppet has been doing. And actually, because of Trexit and some hospitals have stopped transrectal, we are getting more nurses to come to Guys on my list and they can learn. So this is just an example of some of the nurses we've trained where, how many, so for example, there's a young girl at the bottom of the list, her name is Grace. She had never, ever done a local anesthetic transperineal biopsy or a transfaecal biopsy. She had never seen a prostate on ultrasound. But by 60 biopsies, we've got her running independently. She's running biopsy list with me at Guy's. And most of these people, you can see there was actually a nurse from one of the hospital in the UK who actually led the whole service. She brought the procedure to a hospital. And actually now she started teaching her consultants how to do it. So it's been a successful program. And we're noticing that the hospitals that achieve Trexit quickly are the ones that have got nurses doing biopsies. So in some cases, some hospitals are still doing transrectal biopsies and LA and local anesthetic biopsies. Then they'll train their nurses. And we notice that where the nurses are doing them, there isn't much of a waiting list, or wherever local anesthetic transperineal biopsies, there isn't much of a waiting list for patients to have biopsies. So hopefully, as things improve with COVID, we're going to start the face-to-face trainings again. And actually, the British Association for Urological Nurses, they have an annual meeting every year, and they do skills courses where they show nurses how to do flexible cystoscopies, how to do urodynamics. And last year, they actually, for the first time, they've included local anesthetic transperineal biopsies. I hope to continue training the nurses, and it's really it was a passion for Dr. Poppet to introduce Trexit across the country and the world, and it's become a passion of mine, and I'm not using that word lightly. I'll give you an example. Recently, I got offered a job somewhere else where they were willing to pay me more money. But when I spoke to them about training the nurses, they refused for me to continue. So unfortunately, I had to turn the job down. So this is really a passion for me that has rubbed off, that I took from Mr. Poppet to help achieve Trexit. Thank you very much. That's my talk for today.
Thank you, Jonah. Rick, maybe you can arrange for the National Health Service to give Jonah a boost. Our final speaker today is Dr. Matt Allaway. And without him and without Agnes, who's talked in the beginning, we probably wouldn't be having this meeting today. Matt is the inventor of the PrecisionPoint tool. And he's a urologist in Maryland, and he runs a company called PrecisionPoint. And so, Matt, why don't you do your bit, and then we'll go to questions and answers.
Howard, thank you very much for this opportunity to speak to this great organization, the ASPI. I also am honored to be here with Rick Popert, Richard Szabo, and especially Jonah. Jonah's presentation, his journey is really an amazing one. And it emphasizes so many key elements to changing the way we do business, which is having a passion, training. And training is something that is essential if we're going to convert the system to a new standard of care. Otherwise, it may take a couple of generations. But I'm just going to finish off the presentation with a very brief presentation just on this little personal journey I went through. And Rick mentioned this earlier in his presentation, that this idea of going through the perineum is actually not a new one. Back in the 70s and early 80s, most urologists were doing their biopsies through the perineum, and they used all sorts of interesting needle devices. One of the more popular ones was the Vin Silverman needle. All of these different needle devices, they poke through the perineum, and then the urologist placed a finger in the rectum to sort of guide the needle, and then you would pierce the prostate. Of course, there was no ultrasound guiding it. There was no MRI scanning. Many times I mean, this was the true blind biopsy, and many times you didn't even biopsy the prostate itself. It was often skeletal muscle or other surrounding structures. And these men at that time obviously had very large cancers. Otherwise, you would never strike them with any accuracy with this technique. Everything changed in the 80s with the advent of transrectal ultrasound, and ultrasound technology gave us for the first time, the ability to actually see what we were biopsying. And the problem was that although the perineal approach was known to be safer by not going through the rectum, they didn't have the technology to facilitate going through the perineum under the ultrasound guidance at that time. But I'm here to tell you that we are back to the perineum through some of the engineering challenges that I faced in developing the product. It was really infection, as we've heard so much in this discussion, and it was miscancer that led me to develop a better solution. I had started incorporating active surveillance into my practice to a very major level, and I knew that men on active surveillance would have to undergo repeat prostate biopsies. And if any patient had an infectious complication, of course, when you talk to them the next year or 2 years later about the idea of going through another prostate biopsy, the look on their face was pretty clear that this was not an acceptable option. Secondly, I knew from treating men on active surveillance that the biopsies were not accurate. We were missing up to 30% of the important cancers. So men would think they had low grade, low volume disease, when in fact they actually had higher grade disease in areas of the prostate that I simply could not biopsy with the transrectal approach. The work that Rick Poper done in the early, between 2001, 2005 was what we called the grid stepper transperineal approach, which you saw some images in the prior presentations. I, as a urologist in Maryland, realized that there was no way that I could possibly do grid-based transperineal biopsies on all of my patients. Even though I had a grid stepper unit used for brachytherapy right in my surgery center, I knew that this was not a practical approach. It took up to an hour. It required general anesthesia. It required more staffing and resources. The whole apparatus was expensive. It was going to cost about $130,000 for the proper ultrasound and this bulky piece of equipment that required lots of readjustments and it couldn't be performed in the office under local anesthesia. And that was ultimately the pie in the sky, was that we need to do these biopsies ideally most of the time under local anesthesia. And then there was the learning curve, because the perineal approach in the US was just really not utilized, probably any more than about 1% of biopsies. And most importantly, in my opinion, was the fact that the grid-based biopsy approach to the perineum was fraught with its own complications. Men had temporary inability to pee, up to 24% of men. There was a lot of pain because every time you took a biopsy, you were placing this biopsy needle through the entire anatomy to get to the prostate. There were perineal hematomas, there was rectal pain, and men's erectile functioning scores actually reduced about 25%. So I knew that there was really, there had to be a better way. So I developed the freehand transperineal biopsy approach using an angiocath. I actually did some cryoablation of the prostate, and I never used a grid stepper for that approach. So I felt that I could use some of the freehand skills I did for cryo, but instead of passing a cryoablation probe into the prostate, I would position the biopsy needle. So here on my left hand is the ultrasound probe in the rectum, and my right hand is the biopsy needle going through an angiocath. The two are not coupled to one another, so it's like almost a chopstick approach where you're coming from different vectors trying to find the target. I was, in fact, proud of the results, however. I actually had taught other urologists around the US and even in Canada. Phil, I trained the big group in Toronto at the Cancer Center where they utilized that technique and biopsied almost 1,300 men under local anesthesia using this coaxial freehand transperineal approach. Very proud of the fact that no sepsis was encountered and urinary retention rates, not the 24%, but rather 1.6%. Cancer detection was modest in the group at 49%, but better than transrectal. Another group, published and showed that it could be done in the same time frame as transrectal biopsy with a slightly better cancer detection rate in this series. And again, the common theme here, no sepsis. So we were very proud to see that. But I'd won an award at the AUA in 2014. And this was a very new approach. People were throwing rotten tomatoes at me from the crowd because this was a real shocker to say, okay, this is maybe a way to do things differently. And they pointed out that, many patients were still put under anesthesia to do this type of approach in my hands at that time. Number two, it was very challenging to teach it. It was just very, having one hand on one vector, another hand on the other ultrasound probe was not a technique that most could learn. So I realized I had to develop some type of a device, some type of system that could overcome these challenges. And after 3.5 years of development, I pretty much cashed in my life insurance policies and all my savings to try to develop the best mousetrap to execute this transperineal approach. This is an image of the PrecisionPoint transperineal access system, which is the first class 2 medical device ever approved for transperineal biopsies. The grid stepper was not approved by the FDA for biopsy. It was simply approved for brachytherapy, but not biopsy. And there are many features of the device which we're very proud of, but it's a simple, elegant device that has adjustable clamps, cantilevered stabilization bars with bumpers, multiple aperture carriage system, and this proprietary access trocar, so that we could perform an entire transperineal biopsy with simply 2 punctures in the perineum, as Mr. Popert, you could see in his video. As we move into the freehand device-driven approach, the papers have been published, and there's probably at least 6 in press. A couple highlights include this which was done in London under Mr. Popert's guidance, finding that with a device-driven approach, your overall cancer detection rate wasn't the 46% seen in Toronto with coaxial needle or in the US at a 54%, but really seeing cancer detections at or exceeding 70%. In fact, with the device and the methodology, our cancer detection for those with negative MRIs was 61% in this series. And very importantly, is the clinically significant cancer pickup rate was greater than 50%. And again, common theme, once again, no sepsis. Another 1,000 patient series, these patients never had a biopsy prior. None of them had MRIs, and they utilized a device-driven approach using a 10-sector mapping. And again, we see similar results as we saw in London, slightly inferior, most likely because these were not screened with MRIs. So we have 70% cancer detection rates, and again, a greater than 50% clinically significant. Again, no sepsis. What we learned through all of our research was that, and this is very, very similar to Mr. Popert's template, is that we know now with exquisite sampling of men, transperineal, we know where the cancers live. We know this also with all of our research on MRI. So basically everything in the blue and orange are the regions that we choose to biopsy. Everything in the purple and the green are the no-fly zones. And by maintaining this technique with a transperineal approach, you just simply cannot achieve these results with a transrectal. The anterior prostate and the apex of the prostate, seen in orange, can be biopsied transrectal, but if you just think about the simple geometry, in order to get a needle up to these regions, it'd be like poking a stick at a ceiling tile rather than flying right into the cancerous area. In fact, I still believe too that even in the posterior prostate, which is more easily sampled transrectal, is sampled better transperineal, because transrectal inadvertently simply transects the peripheral zone here in blue, and the needle winds up entering the transitional zone in purple, which is an area that does not need to be sampled routinely. And by following this template, you simply avoid the urinary retention because you're not poking the needle around the urethra. And again, no risk of rectal bleeding. And we've been very, very proud of this work. I think, as Jonah mentioned, training is key. This is when I was in Italy, and you can't wait for the residents to go through training programs to convert the system. I spend a large chunk of my life on the road traveling through the U.S. And internationally pre-COVID. And the moral of the story is that we have to get in there in the procedure rooms, in the ORs, working with these urologists. And one other slight little teaser here, because we're all very, very interested in, obviously, in the work of MRI. I'm very proud that the fusion companies, which fuse MRI imagery with ultrasound imagery, have integrated the PrecisionPoint methodology. And this is just a little video clip of how the procedure is done. So basically everything you saw in Mr. Popert's presentation with the device, except we've coupled it now with true MRI fusion. And I'll just kind of scan very quickly. This is a teaching video on the technique. As you can see, we've lined up MRIs and ultrasounds together. And then the lesion here is seen in the anterior prostate. And with the device, we simply fly very easily into this lesion anterior, and we get these very, very thorough samples of the lesions. And then one thing that needs to be remembered is that it's not just about hitting the MRI target, that it's equally important to do your systematic samples. And once we're done with the MRI target, we are able to easily, here's a 3D reconstruction of the region of interest on MRI and where the biopsy cores were taken. And then we can fly through the rest of the prostate and sample every other region of the prostate that might have cancer. We have to assume that the MRI could be wrong, as the lesion may not be cancer, but there may be cancer where the MRI thought the prostate was completely normal. And that's just a little teaser on the MRI fusion approach. So that's all I have to say. I think the other presenters did a very fine job of presenting all the important data. And Howard, thank you once again for this opportunity.
Well, terrific. We'll silently applaud the speakers.